There's a lot of questions about antibodies, treatments, and of course the vaccines. But what are you working on at Johns Hopkins? What are the 2-3 things that you're trying to figure out?
Well, good morning. So we have, in my team specifically, we're really trying to understand the exact extent of this disease and the disparities amongst different people in Maryland. So really digging in deep and trying to figure out, who's impacted, how are they impacted, what are the psychosocial, the mental health, substance abuse impacts, but also looking at PCR and antibody status on all of these patients over a long period of time and see how that impacts everything from their healthcare engagement to their financial situation. We also have teams of scientists working on both therapeutics, vaccines, as well as antibodies.
Jason, until we understand why this virus affects different people that look on paper maybe having the same profile, will a vaccine actually work?
I think it's an excellent question, and we must realize that what we're trying to do is use the exact same strategy in every single person. And so obviously, our immunologic responses, the ability to produce antibody, for the majority of people will be similar, if not the same. But there will be people who are always outliers. There'll be people with different, receptor types, people with different responses, who develop slightly different flavors, if you will, of vaccine response. And so certainly the fact that we've got, 6 or 7 candidates that are nearing, definitely enrolling patients in phase 3 studies is really critical.
Jason, what can you tell us about what type of lockdown works? It seems that, Europe, much like the U.S. in certain regards, is divided on whether lockdowns work or not. What can you tell us?
So I think most importantly, there is clear data now. There are, if you look to the north of the United States and Canada, there are multiple Canadian provinces that literally have 0 cases right now. Now, that's multifaceted, right? Some are in low population densities, but not all. Obviously, Nova Scotia has some larger cities. But what they have done is just really, really practice, I wouldn't say the word extreme, but tight control of the virus. Social distancing, businesses closed, areas in which people combine together are not operational. And now multiple provinces in Canada, for example, have joined a single, area that is a COVID-free zone and allowing people to travel across these 4 provinces, but not from outside of those. So I think we really need to take the local epidemiology. It is painful, unfortunately, until we get a vaccine and an effective therapeutic. And obviously, loss of income and business must be taken into effect. But we have to stop these surging cases because they will stretch our hospital capacity and we will see more lives lost.
But Jason, I thought we were getting much better at treating it. So either through antibodies or drugs or just, knowing when to ventilate people or not. But then when you listen to leaders in Europe, Emmanuel Macron of France, Angela Merkel of Germany, they say, again, it's overwhelming and it's becoming too dangerous for our national health services. How do you square the two?
Yeah, I mean, it's an excellent point. And the issue is that the therapeutics that we have right now, whether they're steroids or remdesivir, or in some cases antibody, although we've recently gotten negative results on the Eli Lilly antibody, and that drug shown to be ineffective in hospitalized patients. We're learning more and more, and each of the therapeutics help some, but they're no holy grail. And so when you see capacity surge and ICU beds taken and ventilator capacity reached, you then have to use other types of wards and units that are less well equipped for supporting critically ill patients. That increases the risk of mortality just by the system itself, irrespective of any therapeutic benefit. So you have to look both at the therapeutic benefit and the small margins that we get there. Then you have to look at the capacity of the health workforce and the system. And as we get into lower levels of care with sicker patients, that mortality may rise. So what they're trying to do is balance the data around small benefit in mortality and morbidity from the therapies with the rising case numbers and trying to mitigate so that the healthcare system can keep up.